Hi, this is Brian Kim. I'm going to share with you this case of a patient with an intumescent white and dense cataract. And I've used the phaco into the central anterior capsule. I've done poking it with the needle and sucking the intracapsular contents out of the bag. But this is the first time I did this mini Rhexis or double Rhexis. I believe it's first described by Dr. Howard Gimbel, where he made a small Rhexis to help reduce the risk for an Argentinian flag sign. A few years ago, I was at the IIRSI meeting in Chennai, India, and I was invited by Dr. Amar and Ashwin Argawal and his team down there. And when I was there, Dr. Pradeep Mohanta introduced himself to me, and I realized that he had a really great YouTube channel. I started watching his videos, and I saw him do the mini Rhexis technique. I'm going to share with you my first experience using this technique. So I use a corneal mark to help me center and size my Rhexis. You can see that this lens is quite swollen and intumescent. It's a white cataract, and it has some level of density to it as well. I'm making my paracentesis incisions superiorly and inferiorly. Again, I'm using the blade to stay parallel to the iris plane, so I have a nice corneal shelf, and this will allow me to get a really nice self-sealing corneal incision. I'm going to inject some intracameral lidocaine, and then I'm injecting some intracameral air. You can tell there's not much space in the anterior chamber. This is quite a big lens, so I'm starting to inject the dye. Again, I like to paint more than inject, and just kind of gently pulse the trypan blue. And then I'm injecting my dispersive viscoelastic. Just wanting to make sure I get all the bubbles out. And then I'm going to do the triplanar corneal incision using the cannula to hold the eye and steady the eye and make a vertical groove. And then I place the blade into the groove, turn the eye away from me, and tunnel through the cornea, turn the eye toward me now, and then enter through. And that's a triplanar corneal incision. I make sure that the anterior capsule is completely inflated, and then I nick the central capsule with the cystotome, hoping this will mitigate the chances for an Argentinian flag sign. And so I just barely nicked the anterior capsule, but you can see it has a horizontal configuration. There's quite a bit of cortical milk coming out. I'm injecting some more dispersive viscoelastic, and I'm flattening the anterior capsule around my puncture mark, and that is to help reduce the chance of a run out. But even as I do this, you can see that the opening is perhaps a little bit suspicious for wanting to go out. So I went back with the cystotome, and thankfully I was able to turn the corner. So I feel a little bit more relieved I'll be able to save this Rhexis without causing any problems with the run out. So I'm doing this mini Rhexis, again using my forceps now. I'm able to get half of it done, and then all this milk starts coming out and it really obscures my view. I'm trying to just gently tap the Rhexis edge down so I can have a nice flap to grab. But as the milk is coming out, it just really obscures my view. So I'm just taking my time. I'm trying not to get too anxious to do anything more dramatic. I was thinking about going with the viscoelastic again, but I changed my mind and just went and said, okay, let's try it one more time. And thankfully I was able to grab it and turn it around. There's my mini Rhexis. So at this point, I'm going to try to remove the intracapsular contents that are liquefied. And so I've seen Pradeep using a Simcoe cannula, but I'm going to use the INA handpiece. And what you'll see is that this lens does not need hydrodissection. These lenses are quite loose already, and you'll see I'm not going to hydrodissect whatsoever. I'm going underneath the anterior capsule, the tiny anterior capsular Rhexis edge opening, and I'm removing all that fluffy cortical material that buoyed up and made the anterior capsule so convex. I'm just tapping the lens and trying to go around circumferentially as best as I can. And as I do this, I can see that the lens is already mobile. And so as I'm sweeping side to side, I'm trying to remove any of that fluffy lens material just underneath the anterior capsule lens surface. I got some lens material stuck in the port, so I mashed it with the BSS cannula, and I'm just going around making sure I get all that fluffy stuff out, because removing all that fluffy stuff will allow me to have a flatter anterior capsule and get rid of that convex configuration, which is the reason why you get the Argentinian flag sign. So as I start to do this, I'm really getting a lot of momentum, and I'm able to move this lens pretty nicely. It's moving quite well, which tells me if it's moving quite well, I must have relieved and removed a lot of that cortical material, and so that's why it's spinning really well. So I come out and then I inject some more dispersive viscoelastic, and I have a really, hopefully, a nice flat anterior capsule, and I place some long Van Ness scissors to cut the Rhexis, and now I'm going to expand it to a normal size Rhexis. So this is why it's called the mini Rhexis / double Rhexis. Mini because it's small first, and the double is because you have to go in twice. And so I'm making sure I go around. It's a little bit hard to get a good, accurate size reference for the Rhexis because my marks are really obscured by all this lens material. But I'm doing the best I can, and I definitely don't want to go too big because I still am afraid it might run out. And so I have a pretty nicely sized Rhexis, pretty well centered, might be a little bit on the small side. Now I'm going to go with the phaco. I lift the incision with irrigation off to minimize Decimase trauma. I tried to remove the surface lens material, but of course I've already done that with the INA. I place the chopper out to the contralateral equator and I bring it towards the center and I try to crush the lens completely in half. Again, this is a pretty dense lens, and so I was not able to get a clean crack, but I'm able to, with gentle force, I turn it a little bit and I'm just trying to tease the lens apart, again, using a little bit of vacuum, using a little bit of cracking force. And I'm just being really gentle because what I realize now, as I continue to separate, you can see there's a leathery attachment posteriorly, and I'm able to separate the lens. So I place a chopper around the lens and I pull it towards the phaco tip and I crush that one heminucleus in half. And then I do the same maneuver against that first quadrant, crushing it in half, and then emulsifying that entire first quadrant. So then I'm using high vacuum to grasp that second quadrant, and I'm just using mechanical fracturing to crush the lens pieces and then emulsify the lens piece. So that was about half of the lens removed. Now I turn the lens in front of me, place the chopper out to the equator, place the phaco tip deep in the bag, and you can see I'm not getting a really nice symmetrical chop. It actually went off to the side, to the right side. So I went ahead and crushed that lens piece and it came out as a small little fragment. And I go back and try to do the same thing. But again, the reason why the lens is not stable is because all of that cortical material was removed. And so that is kind of my first observation. When you remove all that cortical material, yes, it helps with reducing the intumescence. This helps reduce the Argentinian flag. This allows you to get a really nice continuous Rhexis with a lot more confidence and safety. However, what I've done is essentially created a Morgagnian style cataract, where there's a free-floating huge cataract in the bag. I have no posterior capsule protection, and this lens is kind of moving around. And so by using chopping techniques, I'm very carefully and systematically able to take care of this lens. I've been using chopping maneuvers, very carefully crushing the lens pieces, breaking it down into much smaller pieces, making sure each fragment is completely severed into small fragments, and then using mechanical fracturing forces to crush the lens material. Again, I'm using high vacuum, limited amount of ultrasonic energy, protecting the posterior capsule. And that's the thing. When you do this, you have to be very good at protecting the posterior capsule. And I do worry if you're a divide and conquer surgeon and you have to sculpt the lens, that is quite a bit of a mobile lens, and you don't have any posterior capsule protecting you. And so that is my one comment on doing this technique. When you're removing all the intracapsular contents that are milky, you're basically evacuating all of that soft, fluffy material that otherwise would be protecting yourself when you're doing the phaco. And so, again, as long as you can do a chop maneuver and you can disassemble the lens very safely, I think it's okay. But you're essentially creating a Morgagnian cataract situation where you basically have this dense nugget. You really have nothing protecting you from the posterior capsule. So you can see I'm very carefully, systematically breaking down this lens, and you have that really leathery, fibrous posterior plaque that was there, and I just took a little bit of effort to make sure I protect the posterior capsule as well as minimize ultrasonic energy, and I was able to remove that last bit of cataract material. I'm trying to remove a little bit of that whitish fragment, that leafy bit, and so I went ahead and was able to evacuate it without causing any problems. I take the chopper out and then switch it with the BSS cannula, take the phaco tip out and then switch it with the INA handpiece. And this is my way of just maintaining some chamber stability. I start to do the INA sub-incisionally. You can see there's big chunks of fluffy white cortical material. Again, with these cases, you always want to assume that the zonules are no good when these dense lenses. So I'm very ginger about polishing. I'm very ginger about placing that INA tip into the capsular fornix because I don't want to strip any zonules as I'm trying to grab that material. It looks like a fairly clean bag, so I switch to the polish mode and I start polishing underneath the anterior capsule surface edge. The polish mode is very, very safe and it's unlikely to cause any capsule or zonular problems. And so I'm very confidently going around circumferentially in the polish mode. I'm going in the subincisional space where the posterior capsule is, and I'm going bevel down, and you can see that I'm getting occlusion. I'm just using that polymer tip, which is so nice. It's very safe. I'm able to polish the posterior capsule without any fear, and I'm able to really get some of that stubborn remnants that are just underneath me. I'm using the BSS cannula. I turned the INA tip away from it, and I'm going underneath the anterior capsule edge, and I'm doing polishing of the capsular fornix subincisionally. You can see there's a large goomba there, and I'm able to grasp it. Again, I could switch to INA with bimanual, but I'm able to do this without having to switch out my instruments, so I'd rather do it this way. So that subincisional capsule fornix flush is really a handy technique. You can see I'm doing it again, and there's little small fragments of cortical material flying out of the bag. And I have a lot of confidence I'm not going to leave any lens material remnants within the bag. So then I push some cohesive viscoelastic to inflate the bag, and then I take the INA handpiece out. And then I'm placing the capsule sweep, sweeping on the left side first. You can see there's some adhesions of cortical material on that side. So I'm able to sweep that out of the capsular fornix subincisionally. And I'm sweeping again on the left side, and I'm switching now to the right side. This was quite the thick lens, and it had leathery fibrous adhesions. It was quite an intumescent lens. With these dense lenses, I like to put a three-piece lens in, so I'm widening the incision, and I'm putting the three-piece intraocular lens into the capsular bag. I do feel this provides some extra stability, and if there is any late capsular bag problems, I can use the three-piece haptics here to stabilize the capsule in the bag if I need to down the road. So I'm using a Maltzman to help me dial the trailing haptic into the bag. And then I'm going to go in with irrigation off. I go underneath the lens, making sure that the bag is completely clean of any viscoelastic or lens material. So I tap the lens down, making sure that the bag is free of any viscoelastic. I'm removing all the viscoelastic from the anterior chamber now. You can see this is a well-centered Rhexis, a little bit smaller than my usual size. I'm able to polish underneath the anterior capsule a little bit there, but it's a really nice Rhexis. I didn't have any risk of having a tear out or a run out or that dreaded Argentinian flag sign. I push BSS and take the INA handpiece out, and then I hydrate my incisions. So again, this is the Intumescent dense white cataract. This is my first time doing the mini Rhexis, double Rhexis. Again, I watched this video on YouTube from Pradeep Mohanta, and so I'm giving him some YouTube cred, but I know there are many, many surgeons out there doing it. And again, I don't really know who really invented the technique, but again, in my research, Dr. Howard Gimbel was the one who first published this. I think it's a great technique. From now on, I plan to do this mini Rhexis, double Rhexis technique every time I have an intumescent lens. And in my mind, this is really the best way to handle this situation. So I hope this was helpful to you, and I thank you for your attention.